Hello, I'm Nancy Lush from Patient-Centric Solutions. Today we'll be showcasing a record that follows the patient and how user-managed access makes that possible. This video focuses on two enabling technologies and will demo how they work together. You'll be hearing more about trusted identity and authentication. We believe this is an important cornerstone to enabling exchange across care facilities. User-managed access is the glue that binds many of these new technologies together. When providers make their data available via the new ONC rule, they want to know that it really is the correct patient accessing the data. That is, they want to know that Betsy really is the Betsy we think she is. But just as important, when Betsy shares her data with Dr. Bob, she wants to know that Dr. Bob is the Dr. Bob she thinks he is. Identity proofing is defined by the NIST IAL2 standard. We also need high-level multi-factor authentication as defined by the NIST AAL2 standard. When the user is identity proofed, then authenticated to the NIST AAL2 standard, we will enable very high trust authentication. With high-level identity providers in place, multiple healthcare systems can share the same trusted identity provider. This will enable cross-facility sharing. There are many other benefits to this as well. I won't go into them all today. User-managed access, or UMA2 as we often refer to it, is a security standard in OAuth2 extension with the goal of allowing patient-centric management of many disparate records. It defines a standard to make sharing consents computable. It includes first-class consideration for delegation use cases. And it's an underlying component of HEART, which is a set of profiles to enable patients to control how, when, and with whom their clinical data is shared. It works in conjunction with FHIR and existing state-of-the-art security. UMA adds additional components to ensure that patient clinical data is securely exchanged. This is a CMS slide depicting Medicare and Medicaid patient traveling from facility to facility. Often a patient might start in a hospital where she receives her treatment for an acute episode, and then she is released to a skilled nursing facility. She might stay there for a week or two or three, and then perhaps she may be released to a long-term care facility, or she may be released back into the home where she may be cared for by an adult child or another family caregiver. And oftentimes she may receive home and community-based services as well. As the patient travels from each of these facilities, it's critical that her complete medical record is available at the next facility in order to properly inform care. Additionally, CMS has a requirement that each of these facilities, they do assessments at a minimum at both admission and discharge. And at each of those facilities, that information should travel to the next facility in order to properly inform care. There are many challenges and gaps with today's transitions of care communication. We found there's very often poor communication across care providers. Data is often fragmented or even missing entirely. There are medication discrepancies during transitions of care, which can lead to adverse events. It's an increased burden both to provide and access data. Often today, there's a reliance on patient recall. This can often be unreliable. Further, a patient may be unconscious, in which case this option is not available at all. All of this tends to increase patient and family stress. Plus, we have an increased cost and provider burden. In addition to those mentioned above, there are the costs relative to adverse events or readmissions. Then we have those administrative costs. So I know you're all aware of kind of the disadvantage, first of all, that we have siloed data and the many disadvantages of that, but identities are siloed as well. And this becomes a problem in exchanging data across facilities. With a shared identity provider, the authentication can be shared across systems. This reduces both the burden, both at the healthcare systems and the providers. Patient share promotes this notion of the patient record following the patient. For the transition of use case, the complete record travels with the patient from one provider to another, accumulating data. Current accurate data is available at each facility informing care. As a contributor to the PASSIO work group, we've demonstrated this model for transitions of care, exchanging clinical data, including care plans and CMS assessments at multiple facilities across the continuum of care. To give you an idea of how this works, you'll see at the center, we have a transitions of care data hub, which includes a FHIR API. users get authenticated with a trusted identity provider, so they can be identified and authenticated across care facilities. When a patient enters a hospital, the hub may pull data from an HIE to have initial basis for Betsy's care. That information is then available to the hospital, and anything that occurs at the hospital can also be written back to the data hub. For example, the assessments that are done at the hospital will be written back and forth. And of course, at discharge, all of her discharge records would get written back again to this transitions of care data hub. By the time our patient arrives at the skilled nursing facility, all of her complete information would be immediately available to start informing care from the beginning. And then she goes on to the long-term care facility. And as she goes to each of these facilities, the same scenario is in place. Again, across her continuum of care, the patient and family also have full access to Betsy's records. All of this is critical to informing care throughout as she progresses across that continuum of care. This is all driven by a computable patient consent. The patient or the delegate decides who has access to data. The consent becomes the policy that dictates what exchange is allowed. The transparency feature provides insight into when and by whom consents were created and who has accessed what part of Betsy's record. UMA supports sharing data at a granular level. Our current implementation shares data at the FHIR resource level and at categories of clinical data. But there are other sharing paradigms, granular sharing paradigms as well. The same technology can be applied to support sharing sensitive data on a granular level as depicted on the right and as implemented in the SAMHSA consent to share solution. So again, they are sharing our data at a sensitive data level. UMA is a secret sauce that combines us all together. In our example, we rely on external trusted identity providers. We already have many high quality vendors who have this in production. We use enterprise-level FHIR APIs, already well established and proven, and enable that API to support UMA. The consent server both manages consents and interfaces with the authorization server over the secure UMA 2 standard. The authorization server verifies authentication via the trusted identity provider, then interacts with the consent server, the FHIR API, and the client to either authorize or deny access. The client is based on a smart client with just a little extra intelligence to pass additional tokens in its request for information. We would like to change our current transitions of care model where today data is fragmented and inconsistent at best. When we put the patient in the center and we allow that data to follow the patient, accurate data is available when needed to inform care. Let's move on to the demo to show how all of this works together. We're going to start our demo already logged in as Betsy, and this is her dashboard. So of course, the patient has access to her full data, starting with demographics, medications. I won't go through all of it right now, conditions, lab results, assessment, her care plan, and I'll be demoing the rest of that in just a minute. But let's go back to her dashboard. We see here that she has created 3 consents to share data. Let's delve into this consent, this first consent, where Betsy has decided to disclose her information to her son, Charles Johnson. In this case, she's chosen to share all of her information and medical record, but she could have just as well shared only specific parts of her data. And had she done only some subset of that data, only that data would be shared via the consent. She has a term which can be changed at any point in time. And of course, the consent can be revoked at any point in time. Additionally, should we have a transparency feature where Betsy can be informed whenever she's created or changed a consent, or if she would have a delegate, that would be recorded as well. In addition to that, it shows complete access to her history, who's accessed what part of the data and who's accessed what part of the data. So now what I'm going to be doing is logging off as Betsy. And we're going to log back in as her son, Charles. In this case, I'd like to demonstrate logging in with ID.me. So this is, in this particular case, her son, Charles, has already been identity proofed. So he's already known to ID.me. So he's going to go ahead and enter his email. And then his password. and he's going to elect to have his asked to multi-factor authentication sent to him by text. So he's going to continue on here. He receives this code in his text and enters it into this box, continues on, and logging in is just that easy. And now he has access to his mother, Betsy's data. So again, he has access to her full demographics, her list of medications. I won't go through all of this. Betsy has a multiple chronic condition patient, so she has quite a few different conditions. She also has some assessed needs, which comes out of her care plan, which we'll be talking about in just a minute. We have access to her lab results. I'm going to jump down to her care plan. This supports multiple different kinds of care plans, but the particular care plan we'll be talking about today is her long-term care plan, and this is a patient-focused plan. So we talk a little bit about her strengths. It's nice that this plan highlights her personal goals. As an example, Betsy's son is planning to get married soon, and she's very concerned that she won't be able to dance at the upcoming wedding. And so she knows she needs to improve her balance skills, and they've given her exercise to improve those skills and to work on her mobility so that she can actually dance at the wedding. This identifies the various areas that need to be addressed, and these are the activities to meet those needs. It includes, start end dates of each of the activities, the frequency, the costing information, and contact information of the person providing the services. It also has risk assessments and a risk management plan. I'd like to also demonstrate, since we're talking about the PASSIO transition of care use case, we'd like to talk about assessments. And as I mentioned earlier, the CMS requires that assessments be done at a minimum at admission and discharge at each of these facilities. So we see that we have assessments at the hospital, again at the nursing facility, and again at home health services. We can drill down and see the results of any of those assessments at any point in time. And then we also provide an overview of all of the assessments. So in this particular case, there's, for each point of granularity, we'll look at her ability to roll left and right. When she was admitted to the hospital, she really couldn't do that at all. She needed a lot of assistance. And then her condition increased as she transitioned through care. And we see over here on the right is the trend of how that works. Again, because we have all this information available in FHIR in discrete data elements, we can do a lot of interesting things with this with the data once it's transferred by FHIR. Again, we have similar information for self-care along with a summary record. And we started with the functional assessments, mobility, self-care, prior level of function. And then we have cognitive assessments as well. We have the BIMS, PHQ-9. I'll show you the PHQ-9, as probably many of you are aware of what that particular assessment looks like. And any of this information is available as the patient transfers across the care continuum. All right. So all of this is enabled by UMA, where a secure way to exchange patient information. Thank you.